Welcome to Berries in the Interim podcast, where we explore the cutting edge of innovative clinical trial design for the pharmaceutical and medical industries, and so much more. Let's dive in.
Welcome everybody back to In the Interim. I'm your host, Scott Berry. So today we have a special episode. We have another episode on the results of a clinical trial. So we are going to talk about the results of a REMAP-CAP domain intervention on the REMAP-CAP trial. And this episode is coming out concordant with a preprint of the results. And so we will put a link on the website where you can get a preprint. We're hoping you have that as we walk through this result. I think you'll find this an interesting clinical trial, an interesting result, and exciting science. Okay, so I have guests today to talk to these results. I have the chair of the International Trial Steering Committee for REMAP-CAP, Dr. Srinivas Murthy. Srin is an infectious disease specialist and a clinical associate professor, Department of Pediatrics, Faculty of Medicine, University of British Columbia. So we have Canadian representation. We also have Dr. Thomas Hills. Tom is a clinical immunologist and infectious disease physician at Te Toka Tume Auckland Hospital and the infectious disease program lead at the Medical Research Institute of New Zealand. And as Tom was just saying, as we were starting, the flu season is starting in the Southern Hemisphere, so we have representation there. He was the 2024 Sir Charles Herkes Fellowship of the Health Research Council of New Zealand recipient and was a Rhodes Scholar. Interesting. And we have Dr. Lindsay Berry. Lindsay is a senior statistical scientist at Berry Consultants, and this is maybe her third or fourth time on In the Interim. She is a co-lead of the analysis team for REMAP-CAP and also a member of the design team. There's also an unblinded statistical analysis committee that sees all of the REMAP-CAP unblinded data. We, on the design team and the analysis team, only see the results once a trigger has been met and the results become public and the analysis takes place. And by the way, huge thanks to those on the statistical analysis committee. They do tremendous work. Roger Lewis, Anna McLaughlin, Michelle Detry, Mark Fitzgerald, Christina Saunders on that committee. They do a wonderful job. So welcome everybody to In the Interim.
Thank you. Happy to be here.
Okay. So let's talk about this trial. So this is Oseltamivir for the treatment of severe influenza. And we're hoping you have this result. Srin, you talked about this at Critical Care Reviews. You can get a copy of that if you go to the Critical Care Reviews website. You can see that presentation. So that's the general one. We'll get to the results. But Srin, why don't you tell us about the patients that this is going to be relevant for?
Yeah, and so what we're looking at is critically ill patients with confirmed influenza infection. And so influenza, as many listeners know, it's a circulating virus, happens in seasonal disease primarily, causes severe respiratory infections, makes you critically ill. And so what we are looking at is that population, those patients who end up in an ICU because of their influenza infection that's been confirmed by some microbiological test. And the reason we're looking at those patients is that there's not really any treatments available for them. There's a lot of supportive care interventions that we do, but that population doesn't have any targeted therapies that have been found to be useful.
So that's the populations, that's the patients. And what does a typical patient like this look like? Sort of general age ranges of this and severity of disease?
Yeah, and so in the critically ill population with flu, the median age is about 60. which goes along with a lot of different critical illness syndromes. Although influenza affects all ages. And so there's patients downwards to small children, there's adolescents, there's the very elderly. But just like any and most other critical illness syndromes, the 60 to 70-year-old is the burden of disease in the ICUs that's the highest. These patients are very sick. Lots of them require invasive ventilation. If not invasive ventilation, then non-invasive ventilation. So that's positive pressure masks or lots of oxygen via high flow nasal cannula. And so pretty sick patients who all have a probability of mortality at least 10 to 20%, depending on the cohort that we look at across the world.
Okay, so we are going to talk about the use of oseltamivir for and what happened with oseltamivir, and hopefully people have the results here, and so you've seen the results of this. The treatment, the intervention. What is oseltamivir?
I can take that question, Scott. Yeah, oseltamivir is not a new medicine. It's been around a long time, and it's an oral medicine. So you can take it at home, in the hospital. It can be given to critically ill patients, and it blocks the replication of the influenza virus. So it's an antiviral, and it's targeted at the influenza virus. Blocks an influenza enzyme called neuraminidase. And so oseltamivir has been around a long time, and it's been studied in many different contexts. There are randomized trials for the prevention of influenza. Somebody coughs next to you in the hospital in a 4-bedded room, then you might take oseltamivir to prevent the development of an influenza illness and becoming unwell, like Shrin's alluded to. Or you might take oseltamivir very early in the illness at home to try and shorten the duration of symptoms. And there's lots of data in those contexts, but there's no data in critically ill patients from randomized clinical trials. And over the years, what we've known about oseltamivir and how we've used oseltamivir has changed. So as more and more data has accrued, it's become clear that oseltamivir is quite effective at preventing influenza. If you're exposed to influenza and you take oseltamivir quickly, it can roughly sort of halve your chances of developing symptomatic influenza. There was a lot of interest in using oseltamivir very early in the illness. If you're an outpatient at home and you're trying to avoid admission to hospital. And over time, what's become clearer is that oseltamivir is a potent influenza antiviral, and that's why it works for a post-exposure prophylaxis. But its clinical effect in those patients taking it at home very early in their illness is detectable. It reduces the duration of symptoms by 18 hours in the latest meta-analysis published in The Lancet. But because there's thousands of patients in those studies, the confidence intervals are quite tight, and they fall below the 24-hour threshold that the WHO said is clinically important. So oseltamivir, based on the evidence we have in outpatients, definitely reduces the duration of symptoms, but by less than 24 hours, which was considered the clinically important threshold for making a recommendation that it is used in those WHO influenza guidelines. And so we've actually shifted away from using oseltamivir in outpatients, and it's now no longer recommended because we have not seen data that it reduces things like hospitalization or death in that lower risk outpatient community. It does shorten the duration of symptoms, but not by a clinically important amount. That's left us with a situation where oseltamivir is now no longer used in the community, where it clearly does shorten the duration of symptoms, just not by much. And we have patients coming to hospital unwell, as Shrin described, where we really want an effective therapy. And it's that population in hospital, and particularly in ICU, where we don't have clinical trial data. And we've been left with the situation that we don't have data, but those are patients we really want to help. And oseltamivir is widely used. It's recommended in the guidelines despite the lack of evidence. There is some observational evidence supporting its use. And clinicians are looking at sick patients who they want to treat And oseltamivir is a familiar, well understood medication. And so it's commonly given to people in the hospital, and particularly sicker people in the intensive care unit.
Okay. Fascinating. So, and coming back to our experiment, I mean, it's fascinating that it's not commonly used where we have randomized evidence it's beneficial. It's used quite a bit where we have no randomized evidence. We'll come back to generally antivirals in severe disease, perhaps even, as it seems like there's a lack of benefit across a range of viruses. But our experiment was even to the point where we have in the trial, we're going to talk a lot about being randomized to an intervention where you get no antiviral. And we're going to call that the control. So that's one of the interventions in the trial. Oseltamivir for 5 days, and I think that's 75 milligrams twice daily for 5 days, is one of the interventions in the arms in the trial. Another intervention is oseltamivir given for 10 days in the trial. There are sites in the REMAP-CAP global trial that did not want a control arm in severe disease, that they thought that given the guidelines that they weren't going to give a no control. In those sites, they can opt out of the control and they can be randomizing between oseltamivir 5 days and 10 days, which was still an important question to be answered. Do you get benefit from 5 days or 10 days? Are they different in the treatment? So is evidence that this is rather standard. It was even that people sites wouldn't randomize to the control arm.
Yeah, that's correct, Scott. And oseltamivir was so widely used that in many ways you can think of the 5 days oseltamivir as the arm that's most reflective of what usually happens. And then the 10-day arm existed because there are some guidelines and some hospital protocols that say in critically ill patients, you can extend treatment to 10 days. So that was something that was already happening. And in many ways, the experiment here is randomizing away from the receipt of oseltamivir, which is given to most patients as part of usual care. We had a quick look at some Southern Hemisphere data from Australian intensive care units, and it's sort of 80% or upwards of that of critically ill flu patients who get oseltamivir as part of routine care. So it's really embedded in practice. And you're right to identify that for many sites, the experiment was to randomize away from oseltamivir if that site had equipoise to randomize to the no antiviral control.
Okay, so setting up the result, before the trigger of this result we're going to talk about, there were multiple arms in this domain where patients can be randomized. And oseltamivir 5 days becomes the sort of standard therapy that all sites have. And so it's the mathematical connection across all of these. And so that where control, you might randomize patients away from oseltamivir, and control becomes almost an intervention within it. So you could be randomized to no antiviral, oseltamivir 5 days, oseltamivir 10 days, baloxavir, an alternative antiviral, or a combination of baloxavir and oseltamivir, 5 and 10 days. So within that, 6 different interventions you can get randomized to. The result that we're going to talk about was a trigger for oseltamivir 5 and 10 days. We are still blinded to baloxavir or baloxavir plus oseltamivir. We don't know the results of those. So we're going to focus on those 3 interventions is all we know about at this time. Okay, and then we'll tell you how the experiment sort of moved forward. Okay, so the primary outcome in this domain, what is, Srin, what's the primary outcome for this domain?
It good old-fashioned 90-day mortality as a dichotomous primary outcome. So very easy to interpret for a lot of audiences.
How do we analyze that, Lindsay? What's the primary analysis method for 90-day mortality?
So the entirety of REMAP-CAP, we use one overarching Bayesian logistic regression model. So all the patients randomized in REMAP-CAP are analyzed in this model, including the patients in this domain. We include covariate adjustments in the model in addition to the treatment effect. So we adjust for important predictors like patient's age, sex of the patient, location, which is the trial site, which we nest within country. We also adjust for time period of enrollment. We have about quarterly time periods. So from the current time period and then moving back all the way to the beginning of REMAP-CAP, when enrollment started, we adjust for the fact that the mortality rate could vary over time. And then we have other important predictors, including the severity of illness. So whether the patient was in shock at baseline, whether they were on an invasive mechanical ventilation, or if they had severe hypoxemia. And I mentioned this is the same model used for all domains. So we do adjust for whether a patient was randomized into another domain. So we're talking about one, which is the influenza antiviral. If a patient had another assignment in another domain, we would also adjust for that. And then we would see only the intervention effects to which we're unblinded. So there are some parameters in the model that we don't see until they're reported out.
Just to be clear for people, REMAP-CAP enrolled a large number of COVID-19 pandemic patients. They're not in this model. This model is the non-COVID pandemic, as we talk about going back. But we've been enrolling for years this cohort of influenza and non-influenza CAP for that. Okay, so Srin, take us through the result now.
Sure. And so we got a letter from our DSMB in March of this year telling us that the 5-day and 10-day Oseltamivir arms triggered or hit a statistical trigger for inferiority and to stop those interventions. And what that means is we had a posterior probability that those arms were the best in the domain of less than 0.2%. And I think when we got that letter, I think many of us were surprised. I think we all went into this domain hoping to prove that Oseltamivir had benefits. We were more likely to say that Oseltamivir had no effect, given sort of the clinical practice and the feelings of clinicians around the world. I don't think any of us necessarily expected a finding of inferiority. And so at that point, we wrote and quickly put together a statistical analysis plan so that we can report these results as soon as possible. We presented them publicly at the Critical Care Reviews meeting in early June, which were sort of preliminary results without all patients having achieved their primary outcome. And as you mentioned at the beginning, the results are now available on a preprint server for folks to look at also. And what we found is that Oseltamivir was not effective at reducing 90-day mortality in critically ill patients with influenza. And in fact, there was a probability that it was associated with harm or higher mortality in both the 5 and 10-day arms compared to no antiviral.
Okay, Lindsay, do you want to put some probability statements on what Srin just referenced in terms of harm, futility, estimated effect?
Sure. So the outcome was 90-day mortality. The observed rates for the different groups were about 19 and 20% observed mortality for the 5-day and 10 days oseltamivir groups. And in the no antiviral control, the observed mortality rate was 13.7%. In our adjusted analysis, the adjusted odds ratios for the two oseltamivir durations were 2.13 and 2.17. So that's, 1 would be no difference in the odds of mortality. So this is a very, high increase in the odds of mortality. The Bayesian model gave 98 and 99% probabilities of harm, so that the odds ratio was higher than 1, and high probabilities of futility, which we defined as an odds ratio of greater than 0.83, which was our clinically meaningful odds ratio.
Okay. So 98% probability of increasing mortality in this severe influenza population from the primary analysis result. A fairly stunning sort of result given the backdrop of all of this. Okay, what about the result now? And maybe the first part of this is a fairly complicated trial because some patients are randomized where they're eligible for control. And we talked about that. Some sites do not have a control. So in our approximately 500 patients, some of those are randomized between 5 and 10 days, but were never eligible for control. Lindsay, you described in the big overarching model, we have a factor in there that is, are you eligible for the control, which appropriately adjusts and gets the right contrast for that effect. But we also did analyses where you excluded all of those oseltamivir patients that were ineligible for control. And are the results different for that?
Well, I think I forgot to mention that adjustment, but I meant to, so I'm glad you imputed it for me. So yes, the model itself has a parameter, sort of an indicator. Was this patient eligible for control? So we are adjusting for the fact that there could be differences in patients that were at sites that offered control or not. And the model also includes side effects. So there's sort of two ways of trying to address the fact that patients could have different outcomes at different sites. So we report the results in what we're calling this co-eligible population. So these are the subset of patients that are eligible for control and oseltamivir. And the median adjusted odds ratios are very similar. So that if anything, they actually are slightly higher, but the probabilities of harm are still above 90%. So, the qualitative takeaway is the same in this restricted population of patients that are eligible for control.
And there was actually a stunning similarity of the mortality rate on oseltamivir at sites that didn't have control. It was almost exactly this 20%. Something we haven't talked about, and I think it's because it seems not to be an issue, but Srin, there's really no difference between 5 and 10 day results in any kind of meaningful way.
Yeah, not at all. And we looked at that in a variety of different ways. We looked at it with the two arms being nested with each other, which was our primary analysis. If we looked at them independently, or if we looked at them as a pooled estimate. And largely, those aligned pretty closely, telling us that the 5 and 10 day arms were not that different from each other, which is useful information on top of the primary finding.
And I think it's important to reflect on the results in the clinical context that the trial was conducted, because if you'd known that harm might be the finding, you really wouldn't want sites randomizing between one harmful intervention and another harmful intervention. But that wasn't where we were when we were designing the trial. We were designing a trial in the context of most sites using oseltamivir for most patients. And I think if we'd found benefit of oseltamivir compared to no antiviral control, we'd be really grateful that we had the 5 versus 10-day question. Maybe that question would still be in play. Maybe we'd be trying to work that out now by continuing to randomize between those two. But that wasn't the context, and some sites couldn't participate in the no antiviral control. But I don't think we've stated yet that that was a minority of our sites. So most sites were on board with randomizing to the no antiviral control, but a significant minority were not. And so it's important that the statistical model can account for that availability of the no antiviral control. And it's really important to look at this co-eligible population analysis too.
Okay, so let's talk more about clinically what this means. I mean, to some extent, the experiment itself, the sample sizes here, approximately, 300 patients were eligible for control overall, just under approximately 500 patients overall, with this 98% probability of harm. Take us through what this means. Shrin, what does this mean?
Yeah, and I think that's the question for the larger community to wrestle with next. But I think in my practice, my current hospital says every patient who's in the ICU should be getting oseltamivir, or at least they did. And I think that needs to change, and that will likely change. So that oseltamivir is no longer routinely used in the critically ill population with influenza. And this is I'll remind everybody, the first randomized trial in this population. And so if we went back 25 years and had this result then, and how people could interpret it going forward, and would oseltamivir be as controversial in this population or not? Probably not. It's just because it's so established in clinical practice that this result may ruffle a few feathers and may make people ask a few questions about some of the results more broadly.
And Shrin, I think there's 2 questions for clinicians and guideline groups. One is, do you think oseltamivir is effective? And the other is, do you think it's harmful? And they're subtly different questions. And in New Zealand and other Southern Hemisphere sites, we have a bit more time pressure. And so we're grateful you presented the results early at CCR Belfast, because flu's here. And my hospital, our national guideline, used to recommend oseltamivir for critically ill patients. And it's already shifted to say it's not recommended for critically ill patients. And you could make that change if you interpret our evidence as indicating there's no benefit purely because you think there's no benefit. But another way to look at our results is that there's probable harm. And so some might say that our probabilities for harm don't meet some threshold they have in their mind, particularly if you look at the co-eligible population. But I think it's pretty clear that there's no meaningful benefit from oseltamivir. And when there was no randomized trial evidence before, it might be that's enough to shift clinicians or guideline groups. And it might be that there's always this question about, is it definitely harmful? Our results show a high posterior probability of harm, but clinicians have to interpret that when they are familiar with using this drug and haven't felt that it was causing harm. And so I think it's fascinating to think about, how could this drug cause harm? And it's amazing when you find something like this in a clinical trial, you realize there's so much you didn't know about a drug you thought you knew a lot about. I have to admit, I must have missed a couple of days at medical school. I didn't know that we had human neuraminidase enzymes. And even though oseltamivir is designed to inhibit the influenza virus neuraminidase, it seems like it can inhibit the human neuraminidase too, which is important in sialic acid biology. And there are animal studies, there are human randomized trials where clever hematology doctors have worked out that if you randomize half the patients who have an immune problem with their platelets, where their platelets are being destroyed by their immune system. If they randomize patients to Oseltamivir, the people who got Oseltamivir's platelet count recover. And that's because there's an effect on human neuraminidase enzymes. And so it's possible that there's an effect here of a medicine we thought was safe, we thought only worked on the virus, because it works on human neuraminidase enzymes or some other pathway that we don't understand. And that means that critically ill patients experience hazard. We know that patients in the community don't really experience hazard, but I think it's really important to acknowledge that patients with flu in the community and even patients with flu on the ward are very different to patients in the intensive care unit. There's such a marked heterogeneity of clinical illness severity that it seems plausible the drug would work differently across that illness severity spectrum. And we might not understand it, but perhaps it is plausible, even though before this result came out, I wasn't aware of some of that biology and pharmacology of oseltamivir. It's going to be interesting to try and unpick that over the coming months and years.
So, Srin, I found the subgroup analyses fascinating, actually, in the trial, which you should all go look at. Does that back up a little bit of this in community, ambulatory, fresh, infected subjects? There's benefit of this. And as you go to this extreme, we're starting to see potential harm, high probability of harm. The subgroup analyses seem to back this up.
Yeah, and to sort of echo a lot of what Tom has just said, and the heterogeneity of patients with influenza is huge. And even within the ICU population, the heterogeneity is huge. And so within our trial, we randomized patients who are in shock. So they're on vasopressor type drugs to keep their blood pressure up, and not in shock. We randomized patients who had symptoms within 5 days and symptoms for more than 5 days. We randomized immunocompromised patients who have immune deficiencies and patients who didn't have that. And we randomized patients who we thought had a proven bacterial infection at baseline and those that did not. And in every one of those subgroups, the group that was considered quote unquote more sick, the immunocompromised, those were proven bacterial infections. The ones in shock, the ones with a longer duration of symptoms, all had a worse treatment estimate effect with oseltamivir compared to the less sick part of their subgroup, which is fascinating. And I love clinical trials like this, where it sort of asks and brings out even more questions about host biology and how a virus and a very sick individual intersect. And you're giving this drug that you think is doing one thing, and it may not be doing the thing you're doing, but it does open up all these different hypotheses about why these patients become critically unwell, and sort of brings out so many questions about what we do in critical care more broadly.
And of course, we didn't design our trial to answer the question of what's the mechanism of harm. You know, we were trying to randomize people to an intervention that we thought might benefit them, and we were worried there wasn't evidence, and hence we had the no antiviral control at sites who had equipoise, but we weren't sort of trying to tease out any mechanisms of hazard in our design. So unfortunately, we don't have a whole lot of data to answer the question of, you know, what is the mechanism of hazard here?
So Lindsay, this was interesting in that because of the heterogeneity of who we enrolled here, the covariate adjustments mattered. As the trial results. Qualitatively, the story's all the same, but the story became more precise with the covariate adjustments, which is a relatively important part of the primary analysis.
Yeah, and I don't know if we mentioned this earlier, but when you look at table 1, there are some imbalances in some of the baseline characteristics across the arms, and some of them sort of favor oseltamivir, so maybe would be healthier patients on oseltamivir, and some are the opposite. And so I think it was age. The median age was slightly younger on control, but then I think things like invasive mechanical ventilation, those rates were higher on oseltamivir. And Srin or Tom, were there other ones that people mentioned?
It's the invasive ventilation, which was slightly higher in the oseltamivir groups, which people have brought out as an issue. And I think the covariate adjustment, as you mentioned, really does a lot of lifting
so
here.
it was that those imbalances. And then I think another observation is just if you look at the raw mortality rates and calculate an odds ratio, you get something that's about 1.5, whereas the model with its adjustments results in an odds ratio of 2. So sort of where is that difference coming from? And while I've been sort of meditating on the result, I think it's one, the imbalances in covariates and the model adjustments is part of the difference. And then also just the marginal unadjusted odds ratio is just an inherently different quantity than the conditional odds ratio. And we know even in a perfect randomized trial with no confounders, that marginal unadjusted odds ratio will be closer to 1 if there are covariates that are highly predictive of the outcome. So I think some of this is just to be expected because we're estimating an odds ratio. And then some of it may also be the fact that there are these chance imbalances and covariates across the groups. It's hard to tease out exactly how much comes from each part of that.
There's an interesting part to this. So Tom, you laid out and Srin, this idea of even within the severe, the more severe do worse. We've got this understanding that at some level of healthy, that there's some benefit to this treatment. REMAP-CAP is enrolling oseltamivir, before this result, oseltamivir in moderate patients. So these are hospitalized patients that don't meet the definitions that Srin talked about as severe, and we're enrolling that. So here's this result of likely mortality harm in severe. And at the end of the day, at the end of the left-hand spectrum, there's some benefit of this in healthier patients. Now we've got this one step healthier, and a controversial or decision on whether we keep enrolling, and REMAP-CAP is enrolling in moderate patients.
Yeah, and I think we've polled a lot of our sites and asked a lot of people as to whether we've answered the question in moderate state patients. And like you've mentioned, at some point along the spectrum of illness where it has benefit in outpatients and possible harm in critically unwell patients, there's going to be a line where that flips. And where that line is something we're hoping to figure out with continuing to recruit patients who are moderately unwell. And we'll look at the data as per our usual processes with our DSMB, being very careful about what we're finding and making sure that they let us know if it's gone in a direction similar to the critically unwell group. And so more to come on that respect, on the role of oseltamivir in other hospitalized populations, including kids. And I think pediatrics is an area where I think REMAP-CAP has really thought about how to integrate the data that accumulates. And we do interesting things where we borrow from one population to another. And so severely ill children with influenza are an understudied group, as most people know. And so figuring out whether it works in that group also is something we'll continue to evaluate. Once again, stopping rules and DSMB close monitoring and all of those safety issues integrated throughout. And so for everybody, more to come in both of those groups.
This result is 12 and older, I think is what we refer to as adults. REMAP-CAP is enrolling, though our enrollment rate is quite small, less than 12 patients, pediatric. So eventually we'll get a readout of that as well. Okay. within this setting, Tom, does this have an impact? What is your thought? Now, you're reading your colleagues a little bit. Is this somewhat dismissed because I've been using Oseltamivir for years and I never noticed it? Of course, in a single-arm anecdotal setting, would you ever notice it? But does this have an impact? What predicting your colleagues, what do you think?
Well, we're in the thick of it with the flu season, and it feels like the critical care community embracing the result and changing practice here in New Zealand. And I think there are bigger questions for the ward clinicians. Does my patient look more like an ICU patient or a community patient? Because in the ward, outside of ICU hospitalized population, there's also a dearth of clinical trial evidence. I think there's one RCT of Oseltamivir directly compared to no Oseltamivir, maybe 76 patients, and no suggestion of hazard, but only 76 patients. And so most of the discussions we've had have been about, wow, what's the mechanism? What does it mean for those patients on the ward? And then a little bit about the N in the trial, the size of our REMAP-CAP trial, both the bigger group and the co-eligible population, which I think is worth reflecting on because we have published many results from REMAP-CAP with 1,000, 2,000 people in a domain, and here the number is smaller. And so some people might say it's too small for you to say that there's an increase in mortality, whereas another interpretation might be that's a big effect, odds ratio greater than 2. The trial is the right size and derived efficiently from covariate adjustment and things we've talked about. And so we've stopped at the right time. And I think that's an interesting sort of debate and an interesting thing to meditate on, as Lindsay said, because clinicians are surprised by the finding of harm. And of course, you always wish you had more patients to give more statistical certainty, but you also don't want to keep enrolling to a trial where the accruing data suggest you're causing harm just to give more statistical certainty that this drug definitely causes harm. So I think there's been a shift already in most intensive care units, while acknowledging surprise and that the mechanism is poorly understood, and a big question for the ward.
Srin?
Yeah, and I think this idea of it being too small, like influenza studies are hard to do. As Tom mentioned, there's very few inpatient influenza studies because it's a seasonal disease, it's unpredictable in terms of its populations and so on. And so getting an appropriately sized study has always been difficult across many decades of research. And so randomizing almost 500 patients in and of itself is substantial, first. And second, I think the issue of whether we, quote unquote, stopped early is one that I'm sure, Scott, you have many thoughts on as someone who writes a lot about stopping early. But remember, our goal in this study was not to definitively show whether it's harmful or not. Our goal in this study was to show whether it's effective. And I think that has been fairly clearly shown, regardless of your interpretations of when we stopped.
I'm also just incredibly struck by, 500 patients being small when there's zero randomized evidence of this ever before. It's all observational. And all of a sudden, that relative to zero, that's big. In the setting. So it's sort of fascinating, the reception to it. And the other part of it is no study ever of Oseltamivir has shown a mortality benefit in any study ever. And I know we got a result in steroids, for example, that was, I don't even think it was controversial because some studies have shown benefit, some have shown harm. But at least there have been some studies that have shown benefit of steroids. And when the result came out as negative, it was context. Here's the first randomized trial in this population. Now, it's fascinating how moderates come out. And I know the recovery trial are enrolling in moderate patients. So there's more to tell of this story and pediatrics.
Yeah, and
Yeah,
I think recovery might have some critically ill patients too. So it'll be really interesting to see how the recovery data come in. And obviously in the past, we've evaluated some things that recovery also evaluated during the pandemic, and so very different statistical approaches. But it's been interesting to see how the results have aligned historically. And so it'll be really interesting to see what recovery learn about Oseltamivir. One thing that's fascinated me is just how different our finding is from the observational data. And, you could run a whole series of podcasts on reasons that randomized trials might find things that differ from the observational studies. One thing I've been reflecting on is the site effects. The mortality rate from influenza at sites within our study or outside of the study can vary wildly. And so I'm always thinking those observational studies showed a clear association between oseltamivir and reduced mortality. But man, the sites that use oseltamivir routinely must be so different from the sites that don't. And so when you're looking at those side effects and then the patient effects that might influence whether oseltamivir is used, I'm sort of thinking I'm really glad we've got all these covariate adjustments in our model. And I think it's just so hard with observational data like that. And it's on the one hand hard for clinicians to shift away from using something they've also always used. But as you point out, Scott, this is the first randomized trial. So I think people are sitting up and taking notice. And even if they don't fully understand the mechanism and we don't fully understand the mechanism, acknowledging this is the first RCT data in this population and responding to their practice at the bedside.
I just wanted to plug in the supplement of the preprint. We included a sensitivity analysis where we used alternative prior distributions. So our kind of pre-specified approach was a non-informative prior. So we could let the REMAP data speak for itself. But we also considered as this sensitivity analysis a range of optimistic, neutral, pessimistic priors that also varied in strength. So maybe you come in with a very strong belief that oseltamivir is effective, or a very strong belief that the effect is null, no effect. So we have a plot there that shows how much does this new data move the needle depending on where you came in with, what your beliefs were before the study. And I think largely, the results for each prior show that it's more likely oseltamivir is worse than no antiviral, unless you come into this with a very strong belief that oseltamivir was effective. So sort of you started with a 99% probability of benefit, then maybe this data wouldn't move you very much. But in that case, the sort of prior weight is even higher than the sample size of our trial.
Very nice example Bayesian analysis. It's beautiful. Yeah, so check it out. Okay, on the heels, is there anything here or not worth going into as in COVID-19, we had multiple antivirals that all showed harm in that virus. And I'm not aware of a randomized trial in severe disease where an antiviral has shown benefit. Is there an interesting class effect of this result, or you don't even really want to go there at this point, that antivirals, if you've seen one, you've seen one?
Yeah, it's a fascinating question. And I think most of the antivirals for respiratory infections have been studied well in outpatients. And very little study has happened in severely ill. And like you've said, we've extrapolated evidence. COVID-19, we've shown harm with some antivirals, the most studied one, remdesivir, where they studied it across every severity, outpatients, moderately unwell, critically unwell, showing benefit, big benefit in the outpatients, slight benefit in the moderately unwell, no benefit in the critically unwell. And that fascinating heterogeneity across different respiratory infections with the use of direct-acting antivirals it's fascinating. Whether I'm willing to throw every antiviral out in critical illness due to severe respiratory infections, I'd like to see more studies, and we're continuing to evaluate baloxavir, for example, which is a completely different mechanism of action, more targeted towards the virus, as we know of, host effects whatsoever. And so we'll have a more pure experiment as to what the role of antiviral effect is in influenza populations emerging in the near term.
Fascinating.
I think it does teach us that we should think about the pathophysiology in critically ill patients as potentially different. And I think that's kind of obvious to clinicians at the bedside, but sometimes we want to evaluate the same treatments we know have worked in a less unwell cohort. And some of us in REMAP-CAP are leading a domain where we're trying to evaluate interventions that modulate the immune response. So shifting from targeting the virus to targeting the immune response in critically ill patients, and trying to do that in a way that's sensible and acknowledges that there are patients with secondary bacterial infection, immunocompromised, and how do we think about those patients? And I think heterogeneity of treatment effect across the illness severity spectrum and various other clinical factors is the next frontier for clinical trials, and it's going to be something we're grappling with, for decades to come. So it's a fascinating space to be designing clinical trials. And
all right, so thank you all for joining here on in the interim for this important, surprising, very impactful result. Appreciate you all joining.
Thank you.
So until next time, of course, we'll be here on this incredible journey of clinical trial science, science of medicine, statistics. We'll be here in the interim.